Hi, everyone. I'm Jill Harkavy-Friedman, the Vice President of Research at the American Foundation for Suicide Prevention. Thank you for joining us. And today we have a real treat because we have an amazing expert on suicide and suicide prevention, Dr. John Mann. Is it okay if I call you John?
Of course.
Okay. So Dr. Mann is the Paul Janssen Professor of Translational Neuroscience Research at Columbia University and Director of the Molecular Imaging and Neuropathology Department at New York State Psychiatric Institute. And I've had the pleasure of knowing and working with John for, a way long time, close to 30 years for my first introduction. So we're just here. We're going to answer some questions and we'll see where it takes us. But I want to start with John. So you've been working, you're really one of the original workers in the field of suicide prevention, particularly the biology of suicide prevention. How did you come to be in this field?
That's an interesting question. I began my career studying depression, major depression, bipolar disorder, mood disorders, trying to understand their biology. And at some point in time, it occurred to me that most of the research was being done looking at blood tests and measurements in the urine and other things like that. But the problem really lay in the brain, and practically nobody was actually looking at the brain. I was working at NYU at the time. It happened to have the office of the chief medical examiner of New York City on its campus at the NYU Medical Center. And so I got the thought, maybe I should go there and try and get some brain tissue from people who had died of suicide. And I started doing that with a colleague, Michael Stanley. We started analyzing the biochemistry of the brains of individuals who died by suicide because we thought they're all suffering from depression and we're going to learn something about depression. And in the course of doing that, I realized that, maybe a little over half of them have a mood disorder, but the others have all kinds of other psychiatric disorders, and it's important to know which is which. And so I began working to separate people into different diagnostic categories and realized that some of the biochemical findings we were making were apparent in all individuals who died by suicide, regardless of diagnosis. And other biochemical abnormalities were only in depressed people or only in people with substance use disorders, etc. So those biochemical abnormalities that were present in everybody, regardless of their diagnosis, but characteristic of most individuals who had died by suicide, it seemed maybe they're related to the reason they died by suicide as opposed to some other cause. And that was the birth of a new field, the study of the biological abnormalities that characterize individuals who die by suicide.
It's interesting because I've gone back in the literature, and what you're saying as really starting this field is that before you started in this field, people only studied the brain as to how it was damaged when people tried to kill themselves. And the thought that the brain was actually involved with suicide wasn't even there. So you really brought this to the forefront, or the forebrain. What you're really saying then is that suicide has its own biology, just like different kinds of mental health conditions have their own biology. And sometimes, are you saying that when the two come together, you might end up dying by suicide? Is that how it works?
Yeah, so when you sort of map onto in the brain where all the different types of abnormalities, you can see, for example, a type of pattern of abnormality that's associated with having major depressive disorder or mood disorder. And then you can find another pattern of abnormality which is related to the cause of death, whether they died by suicide or not. And it's, in fact, when the two abnormalities are superimposed one upon the other and they occur together, that you have an individual who's not only at risk for depression, But if they develop depression, they become also at risk of dying by suicide. And there's a series of factors that create that risk, that predisposition to suicidal behavior, which have a biology of their own. That's the biology that you find related to suicidal behavior. And when the biology of risk for suicidal behavior occurs together with the biology of depression, that's a high risk group for suicide amongst depressed people.
Okay, so how come so many people who die by suicide then also have depression? But you're saying many of them don't.
Well, that's an excellent point. So depression, we now realize, has become, or is about to become, the leading cause of disability worldwide. It is a very common and potentially severe illness. So those two things mean that it contributes a great deal to ill health and disability around the world. Most people who suffer from depression, as difficult and as disabling as it is, never attempt suicide. But because it is so common, and because suicide is a not insignificant complication of this very common illness, it accounts for a little over half of all suicides in Western countries.
So when you say the brain is related to suicide, how does that translate? Like, what is, like, if you're explaining about, like, what does that do? What does the brain do that leads somebody to take their life?
So the answer to that, actually, we have to take a kind of a step sideways and ask ourselves the question, and we did a lot of studies over a number of years to try and get these answers. What is it that's different about people who are at risk for making suicide attempts when they get depressed or develop anorexia nervosa or substance use disorders or schizophrenia, whatever? What are the factors that make them different? And the most information by far is available from studies of mood disorders. And we find there are four principal elements that place people at risk. The first one is that the brain circuitry for detecting and experiencing depression is hypersensitive in the at-risk group, meaning if a clinician rates a patient's severity of depression, it only bears an approximate relationship to how severely depressed the patient themselves feels. So some people experience depression as more painful than others. And we now know that that's related to certain circuitry in the brain and how the brain perceives and detects and quantifies depression. That hypersensitivity, enhanced sense of emotional pain and distress is greater in people who are at risk for suicidal behavior. It's a trait. It's something that through genetics or early life experience has developed in their brain and molded the circuitry in their brain for detection and perception of depression in a way that makes it feel more painful than it does for other people. So they feel more distressed because of the way the brain's designed. The second, and by the way, we've looked at families and looked at the familial transmission of the risk for suicidal behavior. And we find that indeed this hypersensitivity to depression is transmitted in families and connected to the transmission of suicidal behavior in families, which is an important element in all this because suicidal behavior and its risk, the predisposition to suicidal behavior, is not just a biological phenomenon that happens to arise spontaneously throughout the community. It has a significant genetic element, 50% heritability, and then another significant proportion of familial factors. So it's transmitted in families because of these familial factors and these genetic factors combining. But one way in which those factors translate into risk is through this greater sensitivity to depression. The second factor is decision making. You know, when you get depressed, then you're in a lot of emotional pain and you're presented with some choices. You know, what can I do about this? Should I just put up with it? Should I go and get some help? The doctor just told me I can have these pills. They have a 50% chance of working in the next 6 to 8 weeks, et cetera, et cetera. Or maybe, you know, I feel very depressed and suicidal and life isn't worth living with this emotional pain. I can't stand it anymore. Maybe suicide is an option. So this kind of back and forth and decision-making process taps into a pre-existing circuitry that we have in the brain that's involved in decision-making. And while we all feel we make decisions in a kind of logical, predictable, sensible kind of way, the truth is we don't. The truth is that we don't make decisions that, oops, sorry about that. I'm back. Sorry.
We missed you. We missed you so much.
Right, thank you. The truth is we don't make decisions that way. We make decisions in a very personal kind of fashion where the choices between like immediate reward and delayed reward are very different, and they're highly personal and they're very specific to each individual. And so whether we go for the delayed reward of waiting for 6 to 8 weeks to see if treatments like CBT or SSRIs are going to help our depression, or whether we go for the quick relief of suicide, something in between, that depends very much on how our brain weights immediate reward versus delayed reward. And the longer the delay in the reward, the less valuable it is as an option. So 6 to 8 weeks is a long time to wait for treatment to work. And taking immediate personal action in terms of a suicide attempt has a certain amount of appeal because it's immediate. You don't have to wait. And then if the reward is uncertain and response to treatment is uncertain, it's even less valuable as a result of that. So all of these factors, which we're not really aware of consciously, kind of go into our decision-making process. And the one thing that we've learned is that there's some evidence that depressed people at risk for suicidal behavior are already in a pre-existing way tilted towards immediate reward rather than delayed reward. And they don't even realize that. And the clinician who's trying to help them often doesn't know that either because it's not tested. And the patient listens to the options, goes home and revisits this decision again and again and again as the day goes by, those days go by, in the context of their depression. Now, there's a whole we've mapped in the brain the neural circuitry of decision making. That's a biological thing. And we already know that those individuals who killed themselves, and many of those individuals who made non-fatal suicide attempts and survived, that the circuitry that's involved in this decision making is altered. And it's altered in a way that tilts the person towards immediate reward, meaning making the risk of suicide attempts greater, than it is in the other direction. So that's a second really fundamental way. And there are other aspects like this that have been identified, and each has its own biological element. And together they form the biological picture in the brain that differentiates high-risk people from lower-risk people.
So basically, you're saying that are you saying that people who are at risk for depression are always thinking differently, or in certain states that they're thinking differently? Because my understanding is when someone is in a suicidal state, which by the way could be minutes and it could be years, that they don't also, in addition, they can't wait for the reward, but they don't see that there are other options available, that they have difficulty shifting gears, which is the same part of the brain. So like you said, they start thinking about something and they can't get off of it. And then the other part is that they have more trouble seeing options. So like, that's why sometimes people think, oh, they coped so well, they did so great, I don't understand. Well, even people who could cope well during their usual to them to be stuck in a suicidal state. So you're saying there are these factors, genetic factors and brain factors, but is it set in stone? I mean, is that it? That if you're at risk, then it's the next step is you're going to die by suicide? It's not my understanding. I'm wondering what you think about that.
Yeah, so it's far from set in stone because there's an interaction. You have a certain decision-making profile or predilection circuitry. But then there's the concept of what we call hot and cold. So let's take a person who wants to go lose weight, and they're more likely to make a resolution that they're going to go on a diet after they've had lunch than before lunch. Right? Because before lunch, they're hungry. And it's harder for them to say, wow, I'm going to eat less. But after lunch, they're going to say, you know what, I probably ate more than I need to. Next time, I'm going to eat less. So it's the same thing, this hot and cold. When person is not depressed, there's no pressure on them to make this decision. If they're mildly depressed, there's less pressure on them. If they're severely depressed, there's a lot more pressure on them. And then they're forced to sort of make a decision that they mightn't make otherwise, which is why the part of the prevention of depression is to get depressed people as much better or totally better as possible. Because the more they improve in their depression, the lower the risk, until when they get completely better, there's no risk. So that's one element. You've actually touched on a third area, which is the patient that says to you, doctor, maybe they made a suicide attempt already. And you say, well, what led to you doing that? And they'll say things like, you know what, I couldn't see any other choices. I felt stuck. I'd run out of ideas, ran out of options. I couldn't see any alternative, etc. When one looks at decision-making and emphasizes the kind of problem-solving aspect of this, you find that in more, kind of psychological testing paradigms, one can show that decision-making and problem-solving in the people who are at risk is not as good as it is in people who are not. And this is true even when their depression is better. They're just not as good at making decisions and solving problems and thinking of alternatives. There's a kind of cognitive rigidity that they're prone to. And that doesn't matter if they're not in a crisis situation. But as they enter a crisis situation, which means a progressively worsening depression, these rescue mechanisms, if you like, don't function as well because for them, because they have this already a pre-existing deficiency that they're not aware of and hasn't really mattered in their lives. But when crunch time arrives, that does really matter, and so it does make a big difference.
So, I mean, I think you're highlighting that, first of all, even when a person's at risk, they're not always at risk. They have periods of being at risk. And the other thing is that they can do something to prevent those periods of risk or to minimize them. And then I think another thing is that this is why something like a safety plan works so well. Because in that moment, so a safety plan is a plan that you make up that if you're thinking about taking your life, you have a series of steps you can do. And the thing about a safety plan is it's best if you can do it when you're not in a crisis, so that if you are in a crisis, you have this written plan. You don't have to come up with an idea of what to do. You have steps. What you can do to distract yourself, who you can be with so you feel better, who could you talk to, what are emergency numbers, and then also limiting access to lethal means, which, if you don't have lethal means, fortunately, you can't kill yourself. I kind of think that cognitive rigidity, that inability to, move out of the box actually helps when it comes to lethal means. Because if you don't have those lethal means, you're not going to think of an alternative. You're not going to, in that moment, say, oh, that's not working. Let me see what else is going to work. And the other part is, if you happen to think of another method, it's not going to be lethal. So in a way, that cognitive rigidity almost protects you if you don't have access to lethal means. So my understanding, though, is that we can change. Well, first of all, that suicide doesn't come out of the blue, because you're saying, sometimes you see these little things about a person. It doesn't mean they're at risk for suicide, but if in the context of a mental health condition, that risk may increase. So it's not that someone is walking around suicidal all the time, but they may be at increased risk for a variety of reasons. One is almost always present in people who die by suicide, which is a mental health condition. But then they might have genetics, they might have a head trauma, they might have a chronic health condition, pain. There are so many factors that can contribute. But still, they may not kill themselves unless they're in, everything sort of comes together in the context of stress and with access to lethal means. So that means there's a lot we can do. Now, I understand we have some questions. So how about if we look at the first question and let's see what it is. Okay, what about those safety plans don't work because of systematic suicidal ideation rather than impulsive?
Well, the safety plan is kind of giving people a list of things that they can do that they can't think of themselves very readily, because they're not as able to problem solve, reappraise, reevaluate, see things from a different perspective. So they run out of ideas and just feel stuck. So here they've got this checklist of things that they can do that's been worked out with a professional who's sort of helped them along in putting this all together. So that's a really good idea. And hopefully that safety plan, one, keeps them alive, and two, guides them towards getting some help at a crisis point. Because as you've pointed out, people are only in a crisis, acute crisis, for short periods of time. And our goal is to sort of get them through those short periods of time safely, and then embark on more systematic and more effective treatment of the underlying problem that got them into that state of affairs to begin with.
But so this person's asking, well, what if you just, you're not in a crisis, you're just thinking about it? It makes me think about the fact that, first of all, while thinking about it is a first step to taking your life or making an attempt, most people who think about it don't actually engage in suicidal behavior. So if we look at the numbers, about 12 million Americans in 1 year, in 2019, actually thought about taking their life. About 1.4 million of those actually made an attempt, and 47,000 died. So it raises the idea that just because you're thinking about suicide doesn't mean you're at risk. And for a lot of people who are sort of long-term thinking about it, that risk can increase, for instance, during times of medication changes, when they might be lower on their medication or their thinking is changing. So it still doesn't come completely out of the blue, even when somebody's been thinking about it for a long time. But so what is that you can think about it and never do it, and then somebody can think about it and in half an hour do it? I mean, what do we know about that?
So, we do know we do see that people fall into different categories if you look at the pattern of suicidal thinking. One is a seesaw pattern. That's pretty common. That's probably the riskiest form of suicide, because the person may be a few hours earlier or a few days earlier have next to no suicidal ideation, and then it could become quite pronounced. But this may have to happen at quite a few times over many days, weeks, before the person actually hits a moment where they just decide this is the moment they're going to do something. But what we try to do, that's what the safety plan is for. When you feel that you are in a state where you can no longer feel comfortable or confident that you can resist the compelling nature of these suicidal thoughts, that's an emergency, and you need emergency help. But most people don't feel it in that kind of crisis, and they can actually cope with suicidal thoughts. Some people are very religious, and they would never contemplate actually dying by suicide, even though they may feel that they want to. Other people are taking care of young children. They feel a huge responsibility as a parent, and they also push aside those thoughts. But some people find it difficult to do that at certain points in their lives, and they should go and get some help at that time. But our treatments are also designed to try and help that. If you think about cognitive therapy, which is a way of dealing with negative thoughts and negative feelings and negative urges, so it contributes to our capacity for dealing with these kinds of thoughts. And the antidepressants, they not only, like SSRIs and other types of medication, they not only improve the depression, but they can actually improve the person's capacity for dealing with these kinds of thoughts, reducing the probability of immediate short-term reward responses by suicide attempts, and so on and so forth.
Well, but there's, some people think that antidepressants cause suicide. And you want to say something about that?
Well, that's a very important issue in our society, because the FDA did this analysis of data in 2004 and 2006, first in children and then in adults, and focused on young adults under the age of 26, where they put black box warnings in for every psychotropic medication. But since then, since they did that, there have been 4 times as many studies done as existed before they did that black box warning. And it's very hard to reverse black box warnings. One of them has been pulled back, but the others haven't been systematically reviewed with that in mind. And the newest studies that have happened since 2006, the majority of them have not found this risk. They actually find the opposite. When we look at larger studies with bigger numbers, particularly using, say, meta-analyses of very large-scale populations, we see that the efficacy of antidepressants was generally underestimated by these smaller studies, and the risk of suicidal behavior was overestimated by these studies. And in fact, when we look at the patients before they started their antidepressants compared to after they started the antidepressants, you find that the greatest risk period by far of suicidal behavior in patients being treated with antidepressants is in the month before they start the medication, not after. Afterwards, then the risk is greatest in the first month, and then it declines progressively. But even in the first month, after they start the medications, the risk is lower than it was in the previous month before they started the medications. So it is very possible that some of this black box warning information emerged as an artifact of this phenomenon that the people getting the medication are actually coming off a higher risk period before they started the medication than compared to afterwards.
It's so interesting with the FDA because, well, a couple of things. Those studies never had baselines, so they don't even know about people's suicidal, the studies that they used to make the decision. They couldn't even see if it was more suicidal ideation behavior because they had never measured them at baseline, and these people were coming in for help because they weren't well. And then the other part of it is that it's not that people died in these studies. I believe that nobody died in any of the studies that went into the FDA warning. And then the third thing is the warning just says, which you should always do anyway, if you start someone on new medication, follow them closely until they get settled. And so as a patient, you also want to make sure if you're starting a new medication that you're having ongoing contact with your clinician and discussing with them any side effects that you're having, because occasionally some people can get agitated, very small group of people, but it can happen. So the black box warning just means if you're going to use them with kids, but really with anybody, this is the case, follow them until they get settled on their medication. Now, I have a pet peeve about the black box warning because since they put that on the antidepressants, they've been measuring suicidal behavior every session. And nobody's ever looked at those data to see, do they actually relate to suicidal behavior at all? And now we have thousands and thousands of cases of people who've been treated with antidepressants, and we need to look at those data. So we have a new question. I have a few pet peeves, but that's one of them. Let's see our next question. And we have so much to cover. You know, the brain is very complex. Okay, can you talk about the difference between suicidal ideation and suicidal tendencies?
That's a very good question. It actually taps into something that Jill said a few moments ago, which is the difference between high-risk people and lower-risk people is not necessarily whether they get suicidal ideation or not. It's whether they act on the suicidal ideation, which is why you see that a lot of the predisposition is about how people respond to having suicidal ideation in terms of how they make decisions, how they kind of formulate their situations so that they find the ideation less compelling, and how they distract themselves from the ideation, how good they are at help seeking when they get the ideation, and so on and so forth. So a lot of elements differentiate people who make suicide attempts from people who have the ideation. However, having said that, the people who are at risk for actually acting on suicidal ideation will sometimes describe a form of ideation which is more serious and is the kind of ideation that prompts us to send people to the emergency room to be considered for admission to the hospital. And that is that they experience the ideation as compelling, meaning it's severe, it's ideation that is more graphic and complete. It comes in the form of thinking about actually how they would do it, a plan of action. This is the, if you like, the transition from suicidal ideation, life isn't worth living, I wouldn't care if I didn't wake up, or somebody bus knocked me over in the street, it would be a relief. But this person doesn't actually plan to do anything. Their ideation is more passive. If something happens to them by chance, they're not going to be sorry. That ideation is a terrible thing, but it's less serious. But if the person is actually thinking and ruminating over, how can I kill myself? Should I hanging, gun, pills, overdose, jump out of
But we don't really want to share methods of ways to kill yourself. So,
but,
if they're thinking about what they're going to do, and they have detailed plans, or even if they have imagined themselves not being alive anymore, I think is what you're talking about, that severity, that they're very involved and connected. And
if people think about what they're actually going to do, that's at a different level of seriousness. And if they also have the feeling that these thoughts are hard to resist, that is an emergency. That is a huge life-threatening crisis in the life of that individual, and they or their family or friend or anybody who has some inkling that this is going on should be helping them to immediately seek help.
You know, it makes me think about the question before about people who have, you know, long-term thinking about, they're not in a crisis, but they're quite serious about it. And that it's very important to engage and help, because a person like that is probably still in the throes of a mental health condition that's not fully treated. And then on top of it, their thinking, like we said, is probably they're thinking, I'm a burden to people. People will be better off without me. And that's the thinking that we were talking about before, that sort of not being able to see the future, not being able to wait to see what happens. And so I want to get back to that question, just because they suggested that maybe a safety plan wouldn't work for them. But I think that's a signal that getting help, like you're saying, is really important. Just because someone's thinking about it for a long time doesn't mean that they're not going to act on it impulsively, or, you know, what's going to make that decision. So, but it reminds me that it's still that thinking that seems logical to them. I'm a burden, so I might as well not be here. People will be better off. But that same person will say, I love my family and my family loves me, but they'll be better off without me. That is completely illogical. That's not what love is. So it's that kind of thinking that somebody could actually think it makes sense, but it doesn't really make sense, because there's always something you can do to make things better. Even, you know, we've seen people suffer with incredible health conditions and push for every last second they can get. So it's complex. Suicide is really complex. Um, and that's shift from ideation to action we don't get. But John, I think you pointed out some really important ways to try and get someone to help. Now, sometimes we get them to help, but unfortunately, so far we can't prevent every suicide. And we have to, you know, understand that if it happens, ultimately it's the person has to give it a whirl, give it a try, be willing to have at least a little bit of hope that things can get better, and allow somebody to help them.
That's difficult. When people suffer from, most of the suicides are occurring in the context of a person being in a depressive episode, which is, of course, is really a medical problem. That when they're depressed, in underwater, as it were, psychologically speaking, in a depression, they have certain changes in the way they perceive everything. For example, that's when they feel pessimistic. They don't see, when they're depressed, they can't imagine getting better. They feel there's no way you can get better when you're in this kind of state. They have a certain inbuilt pessimism that comes with a depression. And so we try to explain, look, hang on there, when the depression will get better, even though you don't believe or feel in your gut that this depression is ever going to get better, the treatment works. It doesn't require you to have faith in it for it to work. It'll just work anyway. And then you'll see things differently. And the same thing, that idea about being a burden. People who are depressed have feelings of low self-esteem, guilt, and being not very lovable. And they feel a burden to others around them. And they actually feel that they're doing everybody a favor by kind of getting out of the way. But that's only when they're depressed. When those people get better, they don't have those feelings at all. Suddenly that distorted perception disappears, and they start to react to the world like everybody else. They feel like a member of the family. They've got something to contribute. Their self-esteem bounces back. Life, there's hope and a future to look forward to. So it's all built around the severity and the nature of this depressive illness that they're afflicted with. And that is treatable. And our job is to keep people alive and get them the treatment they need in order to get out of this dark hole that they find themselves in.
And so many people, when they feel better, they've experienced just what you're saying, and sometimes can't even believe it, that they are the same person and that they actually have the life that they have. So let's see if we can take another question from the audience. Thank you all for being here. And by the way, come to our website, afsp.org, for lots of information about how to prevent suicide and about mental health and all kinds of things. Okay, so I think we have another question. Okay, have you formulated a tool or set of tests to predict risk for suicide? I work in suicide prevention as a peer support worker. Feel like none of our methods of assessing risk are very helpful or accurate. Great question.
Okay, that's good. So we know that certain things are helpful. It is difficult to predict the risk of suicidal behavior and timing of suicide in people. That's true, but it's not. But we can identify higher risk people, and the way we do that is by asking people, about depression. Now you may say, well, that's really simple. And in fact, how do we know that this is helpful? We know this in a couple of different ways. First of all, there have been many studies now, controlled clinical trials, where people have been, where we've looked at what happens when you train a set of GPs, primary care physicians, in the recognition of depression and how to treat depression better. So these GPs are not even trained to ask about suicide risk. They're only trained to treat depression more effectively, make a diagnosis and treat it more effectively. That seems to lower the suicide rate significantly, maybe by as much as half. And it's really impressive. So here's a rampant illness which is undertreated in our society. And if you look at people who die by suicide in the US, 78% of them who have a psychiatric illness at the time of death were untreated at the time of death. So most suicides are occurring in people with an untreated psychiatric disorder, of which the majority are suffering from a mood disorder, depression, major depression. So that clearly, even if you just diagnose people with depression and got them along and got some treatment for them that's effective, you're going to save a lot of lives just by doing that.
Without even predicting whether or not they're at risk for suicide.
Exactly. Now, you can improve your performance and success by asking people about their suicidal thoughts and what they consist of and what's going on in their lives, how they're feeling, and what impact are these thoughts having on them and how they cope with them, just along the lines of the little conversation that Jill and I had a few moments ago. And by that, you will discover another subgroup of individuals who really need very urgent help. You'll find other people where it's not quite so urgent, but they do need help because in a future occasion, they may find themselves in a crisis. But in the meantime, the people with the compelling, very graphic and specific suicidal thoughts, they need urgent help, very urgent help. And you can find some people like that and send them along for help. A third group that you can focus in on is a group of people who have presented in a suicide crisis, either thoughts, compelling thoughts, or actually having made a suicide attempt that they survived. Those individuals are at heightened risk for particularly in the first week, then month, then 3 months, then 12 months after they've been through that crisis. Outreach to individuals like that. How you doing? How's it going? If you need any help, we're here for you. Just reminding them of the availability of outreach and just showing an interest in them can halve the rate of suicidal behavior in those post-crisis 12 months in those people. So that's a big thing. You may not see that if you're on a call center, or you may not see that even if you're working as a peer support worker. But that's what the data show. So there's a lot of room here to be helpful and do some good.
Yeah, I think that what you're saying also is that we can predict better, not great, about lifetime suicide risk, but with the person sitting in front of you, they can't even always predict. So, we can't. We're learning about it. We know what some of the risk factors are, but then it takes, close monitoring, helping to take care of people. And if they don't have depression, the likelihood is they have a substance use disorder, or they have psychosis, bipolar disorder in a depressed state. So that's depression, even though it's a different kind of depression. So they have something, remembering that not all people with mental health conditions are at risk for suicide. But treating that, while it doesn't solve the whole problem, brings the risk level down. And then limiting access to lethal means can reduce the rate of suicide up to about 40%. It's really amazing. So if you put treating people for how they're doing mental health wise and limiting access to lethal means, we can reduce suicide quite significantly, which I think is what you wrote in one of your summary papers. And then recently you revised to say, and also treatment. So, Dr. Mann, John has spent a lot of time looking at this bigger picture. And the conclusion is we may not be able to predict it, but we can do something about it. And that also comes from just having a real conversation with someone. And if you're not sure how to do that, we have these great real convo guides. And if you're talking about a teen or young adult, we have the Seize the Awkward campaign. And these provide information about how you can have that conversation in a safe and non-judgmental way, to say, hey, I've seen you're not sleeping, you're not going out with your friends, what's going on? Are you feeling so badly you've thought of ending your life? I'm here to listen. I can't fix it. I can help you fix it. So, get that conversation going. So, but most of us aren't sure how to have those conversations, and that's why we have these real convo guides. So please check in on them. Let's take another question before we have to hop off. We might even get 2 in. Let's see. What about those of us who have become completely medication resistant? That is a really important question.
So the short answer to that is that my colleagues and I only treat people who feel that their depression has become medication resistant. It's not the person having become medication resistant. It's the condition that the person is suffering from that is may become medication resistant. So the short answer to that is that we have evolved treatment approaches that work for most people, even if there is a long history of failed medication trials. And it's a bit like the treatment of hypertension, where there are half a dozen different categories of medication and treatment. And by using combinations rather than single treatments, and designing the combination for the individual patient, one can achieve responses even in people who've so-called been depressed most of my life, seen lots of doctors, and I've tried every medication in the book. That's the only kind of patient we actually see, but we get a lot of these people better. So one should never say completely medication resistant. There are newer medications coming along, and there are cleverer ways of using the existing medications. So people should be, should persist. Find another doctor, get another opinion, keep pushing.
Yeah, I think there's always reason for hope. And what I always think is we're trying to get our brains back to this multi-transmitter, multi-chemical system. And when we're having a mental health condition, that system is off. So to think that only one medication is going to do that, it's like pushing a boulder up the hill. That's why most people have to have more than one medication, because we're trying to get the brain back to where it's functioning optimally. And also, we funded a study by Lisa Pan where she found that some people they have some problems with their metabolites, things that you metabolize. And she studied a whole series of these metabolites, which have to do with your proteins and eventually with the chemicals in your brain. And some people had very specific deficiencies, and they weren't processing. So, like folate was one of them, but it was highly individual. And when in those few people who had what they called treatment-resistant depression, when they identified what the deficiencies are and provided the supplement, because that's what a deficiency means, you don't have it, the people actually got better and the suicidal ideation went away. So I think, if someone tells you what you're saying, John, is if someone tells you you have treatment-resistant depression, find somebody who's willing to work with you to help find the combination, and know that you have to have a combination. The other thing is, keep in mind that when you're feeling well, stay on whatever you're doing. Like the tendency is, I feel better, now I can stop this medication. And that's medication resistance in your thinking, not in your actual. If you're feeling better on medications, that means great, stay, don't change it. It's working for you. And if you're not feeling great, then you need to talk with your clinicians. And also, the combination of therapy and medications together is more potent, more effective than either one alone. And it turns out we funded a study that showed that the brain, for people who had certain kinds of deficits, deficiencies in their brain function, therapy, in that case dialectical behavior therapy, actually changed brain function. But if you didn't have that deficiency, it didn't work that well for you. I mean, eventually it would work, but it took a long time. So we need to learn to match our treatments to the individual. And the other thing that I always tell people I'm working with who are starting antidepressants is, you're going to look better before you feel better. So don't be surprised if people start telling you, oh, you're back, you're feeling better, and you still feel crummy inside. That's a good sign, and it means that it's coming, that you're going to start feeling better. And that's a point where some people have that idea, oh, people are feeling better, so they act on it. But it's also possible that people see them feeling better, but inside they still feel crummy, and that might make them a little isolated and feeling alone. So if people notice you're changing before you change, then that's a good sign, and that change for you is coming soon. So I think that we're going to need to end today. Did we already discuss the last two talking points, after brain circuitry and decision making? Oh, those were the two brain talks, that your decision making is based on your brain circuitry, but that could change. There's flexibility. It's it must come from the 60s, when plastics were really in, and they called there's plasticity, because now plastics don't bend at all. But there's plasticity in the brain, and so even if you have that brain circuitry, and honestly, Dr. Mann has an amazing, important theory, has identified neurotransmitters that are related to all of this. That's another talk. But John, do you want to add anything before we end?
No, it's the truth is that yes, the brain is the machine that does all this. So of course, when psychotherapy, medication, or whatever treatment it is, modifies people to make them feel better, we can track that effect by looking at different aspects of brain function. So the two kind of go together. It's not a big surprise. And I think your point about treatment and treatment resistance is that's a critical thing. When people have hypertension, we know we must lower the blood pressure down into a safe zone. Otherwise, they're at risk for stroke, myocardial infarction, and renal failure. These are the complications of inadequately controlled blood pressure. The same with diabetes and glucose and so on and so forth. So, but in hypertension, if the first medication doesn't work, we will add a second medication. Not very high doses. We just add enough to have a therapeutic effect. But each of the medications comes from a different class. So the therapeutic effect adds up from the different classes, but the side effects don't remain relatively mild and tolerable, because they're not adding up, because the medications are from different groups of types of drugs. That's exactly how we treat depression. We don't treat with one and that didn't work and jump to another one. Oh, that didn't work, and then jump to a third one. That's not how to do it. There's a systematic approach tailored to the individual, just like hypertension. If we want to get your depression 80% or more better, that's the goal. And we can fiddle with the medication, aiming towards that 80% better. When you get better, there should be no question in your mind or anybody else's mind that you are improved. There's none of this wishy-washy, maybe. No, it's got to be distinct. That's what we're aiming for in treatment.
Thank you so much. We still have a few more questions. We'll try to answer them online, but thank you so much for being here. I know there's a lot of ideas about the brain and medication and what works, but the truth is there's every reason to have hope and to keep trying, and you will find the thing that works for you, whether it's therapy, medication, some combination of the two. Also, self-care, eating well, staying hydrated, exercising, working on your sleep hygiene. All those things contribute to a sense of well-being. So thank you so much, John, for being here and for sharing your expertise. And thank you all for joining us today. Bye.
Thank you.